And welcome to our March Q&A live session. And as you can sense, for those of you attending the live version, live may bring some interesting things along with it, but that's part of our intent with these sessions. We wanted them to be less formal, but definitely informative. So not kind of a one-sided, here's a bunch of slides from Dee and I, and talk, and maybe you get a few minutes at the end to ask a question. We wanted this to be an open forum. So the Q&A box is available to you throughout the presentation. And it doesn't necessarily have to be on, if we're answering one question and your question is on a different topic, that's fine. Go ahead and put it in the Q&A box. We're going to be monitoring those throughout the presentation. We also do an open call for questions before we start the session. So Sherry's the keeper of those. And so Sherry, can you kick us off with the first topic and or question that we're going to be tackling today?
I sure can. We had some that were submitted to us early, so I'll start with a couple of those, and then we'll go with the one that's already in the Q&A box, which is a great question, by the way. Thank you, Cindy. We are literally getting bombarded with questions about maintenance therapy and a new issue that has arisen in maintenance therapy, which is the ability of the assistants to do the maintenance therapy in the home. However, there was some confusing guidance that came out about whether or not the PTA can provide Part B in the home. So Cindy or Dee, either one, would you like to address that issue? Can the PTA provide Part B and do it as maintenance in the home setting?
I'm happy to take that, Sherry, because I've been digging through the resources trying to help folks navigate that particular issue. Because I will admit, I'm just confused as everybody else. If you go look at the regulation as they stand today, and I literally double checked it yet again before we went live today, the regulatory language in Chapter 15 still says that therapy assistants cannot provide maintenance. What we're seeing is actually a lag in their updates. For the 2021 fee schedule, they did correct that. They intend that effective January 1, 2021, PTAs and OTAs can be active participants providing maintenance therapy under Part B. And that could be a Part B business in the home. It could be Part B in the outpatient clinic. So technically, right now, yes, assistants can participate. But if you're looking for the actual regulation to state that with a corrected update date next to it, they haven't done that yet. So we do have reputable resources out of entities such as the APTA that confirm that from the physician fee schedule, but I think it's caused some issue with respect to understanding that for those of you who do Part B in the home. So I'm happy to see it, quite frankly, despite the temporary confusion, because it levels the playing field. Trying to keep track of which setting an assistant could or could not provide maintenance therapy in just added to the confusion. And I think they're finally getting it to where it really doesn't matter the setting. Both the therapist and the therapy assistant can provide it. But if I can tack on to that, Sherry, because I'm going to punt this question over to Dee. On the heels of this, so yes, they can. Yay! There it is in the regulation. And starting in 2020, assistants could do that in home health as well. But I'm hearing from folks, Dee, kind of it's so good assistants can participate now in maintenance, because maintenance is really, kind of doing the same thing with the patient over and over again. Does that really take, the PT or the OT? This is great because now I can just give the maintenance visits to all my assistants. I'll just have the PT or the OT do the evaluation, mandatory 30-day, and just like goes on very often with restorative care, just give it all to them because it's just maintenance. Do you have any thoughts on that?
Yeah, actually, we have to remember that there's two variations of a maintenance course of care that's provided under the Medicare benefit. One is what you and I call condition two, is where we set up and establish a program, train the patient and or caregivers or family members, and oversee the patient and the program and provide regular updates as to how the patient and the program are doing, right? Is the patient, family members, whoever's trained, responsive to the program? And is it the right program for them? So that's like condition two. And condition three is where we're actually, because the acuity of the patient or the complexity of the program requires the skills, knowledge, and abilities of a therapist, or a therapist who supervises now an assistant, PTA, CODA, under them, to provide some or all parts of that program because a layperson can't. And so when we think about this variation, it's not just are you getting maintenance or aren't you, but who is actually carrying out that maintenance program, and does it require the skills of a therapist? So I would say under condition 2, that really is within the purvey and the licensure of the qualified assistant, the speech language pathologist. They don't have assistants, right? The PTA, the PT and the OT. So that really isn't where the delivery of care is happening by the assistants. That's happening under those parts or all of those specific programs where the skills, knowledge, and ability, due to the complexity of the program or the complexity or acuity of the patient is such that only a skilled person can do it, which doesn't translate, Cindy, into a well, no one's available, therefore we have to do it, right? Just think holographically. If someone materialized in front of you and said, I am willing, and you determine them to be capable, would you train them? And if the answer is yes, then you shouldn't be providing that part and they wouldn't fall under that condition 3. And so the assistants come into play under the condition 3 component, where we're actually delivering some or all of the maintenance program, but not under that condition 2, because really that's the skills of the therapist, right? We're setting up, we're delivering, we're evaluating, we're modifying that program, we're modifying any orders or goals or anything that comes with it. And that stays within the purvey of the assistant. Excuse me, of the qualified therapist. Why do I keep saying the assistant? That stays with the qualified therapist.
So
And,
I mean, it really
what?
comes down then to how you're going to manage that episode of care and make sure that, you know, the things that are about driving the program, changing the program. And wouldn't you say it's fair to say, in my opinion, it's no different than what the roles are in a restorative focus of care, about who
Yeah.
can create a plan, change a plan, update and change goals. That's the purview of PT. OT, care delivery that requires skill, would be the PTA or the OTA. So I just wanted folks to kind of, because I'm getting quite a bit of that lately, Dee, about this almost sigh of relief that now we just can offload all of these, and we really do need to be careful.
Yeah, well, I think this is where people get really confused, because who we are as clinicians and what our licensure allows us to do and doesn't allow us to do does not change, right? These are just the delivery of care. The one fundamental difference between a restorative course of care for a Medicare beneficiary, Part A or Part B, and a maintenance a course of care for a Medicare beneficiary is simply what we're looking for the desired outcome to be. Are they on a track for improvement, recovery of function, return potentially to a prior level of function, or are they on a course of care for stabilization, for prevention of deterioration or decline, to slow naturally occurring deterioration or decline in progressive disease processes? And that's where diagnoses come in, right, Cindy? I mean, what do we always hear about diagnoses related to maintenance programs? I want to ask you that, and where does diagnosis actually fit in determination of care?
Oh, I had someone just this morning very frustrated with someone in her organization who insists that the only way to get maintenance is they have to be a neurological diagnosis, that they can't be anything else. And really, this is where I think we've created so many fake requirements related to maintenance, as opposed to maintenance is simply our target has shifted. Our target is to stabilization of function as opposed to improvement of function. All other regulatory parameters and skill assignments and documentation expectations, they're all the same. And the diagnosis doesn't determine whether you're restorative or maintenance or even need therapy. It's a factor under consideration, but it isn't a gatekeeper. And I still see a lot of that idea that this sticks with hips, knees, and strokes. But Sherry, I see we're getting questions that are offshoots of the maintenance conversation. So which one do you want to start with from our folks
Well,
today?
first of all, I wanted to do a shout out to Dee for clarifying that assistants are qualified therapists. I really appreciate that as a PTA. That's super important to know, because there's a lot of experienced assistants out there that can do a lot of great things in the home. And thank you so much. But this next question is a two-parter, and it's from Cindy Moore. And I think it's probably going to go to Dee, Cindy, because, you know, all hail the tests and measures queen with Dee. So the first part of it is, can you offer a good example of an agency operating primarily under PDGM that is offering, and I dare say even marketing, skilled maintenance therapy service? Let's have a moment. Hurrah! Claps. I wish I had a soundtrack. And are denial risks less of an issue in PDGM? Seems like there's a paucity of validated standardized measures that can be used for patients with moderate to severe cognitive impairments. In this situation where skilled maintenance may sometimes be appropriate, is it acceptable for the 30-day reassessment to contain description rather than validated functional measures?
Cindy, you going to take part one?
Sure, I'd be happy to. Are there agencies doing this? Again, I must have had, all the planets in alignment for my activities prior to today's call. I was talking to one, and they are very much involved with providing maintenance therapy, and very significant amount of their patients are in a PDGM payment model. Their methodology, they said, actually increased maintenance in the pandemic, because they viewed this as an important opportunity to evaluate their current patients and patients that were coming on service during that time, and look at them from the how are we managing risk? How are they qualifying for home care? Many of their patients were qualifying, initially by a medical or not a medical, by a mobility and or cognitive related issue, the more traditional homebound status. The majority of them stayed under that, but a lot of it had to do with physicians not wanting these folks out and about during the pandemic, and so seeing the physician restriction to reinforce that they are homebound. But approaching this as how do we make sure that we have taught, trained, monitored, reinforced what's going on with these individuals, and have seen a significant reduction in rehospitalization rates for these individuals on a maintenance program. I won't say it's not without challenges, because again, there is educating referral sources about what maintenance is and what it is not. As Dee said earlier, it is not a substitute for no caregiver. It still has to require the skills of a therapist. Also, helping the clinicians understand how this works, that again, it's not substitute caregiving, but really how to embrace that role in stabilizing function and preventing further issues. And being clear that it's not every single patient under the sun goes there. One of the steps they implemented was essentially a vetting process, as it were, before deciding to discharge, to really make sure, have we taken care of this to the point under the restorative model that we are confident that they will remain stable without our services, or do they make sense to shift to a maintenance program? And so they've seen, while agencies in their competitive market have been talking about declines in their patient census over the course of the pandemic, this organization has seen significant growth and maintained that growth through all of these events. So it was an interesting conversation, Dee, because it wasn't, sometimes what makes you and I nervous. We put everybody on maintenance and we can keep these patients till they pass away no matter what. No, that's not quite how this works. But to see an organization say, listen, we're looking at all of these things, and they felt the pandemic had given them an opportunity, even more so, to exercise and stretch in this part of the benefit appropriately and be able to keep people out of higher cost care.
Yeah, and Cindy,
Yeah.
I've actually seen where agencies say they have done anywhere between 10 and 25 or 30% of their existing therapy caseload on maintenance. So again, I think that if we're always looking at what is appropriate to fit the beneficiary, and we have a very solid decision-making process with a strong understanding of the regulations and what therapy, the need, reasonable and necessary skilled therapy is used for, treating the kind of patients we're seeing now. Let's just look at the pandemic. These people that are experiencing long COVID, right? These effects after COVID of the respiratory or the cardiovascular system. These are the kind of conditions that if we're looking at improvement where we really don't know that people are going to be able to return, it really doesn't come down to diagnosis, and a solid understanding of this is what therapy is for can really open up that component of the benefit for an agency. And again, as you say, as we look at our outcome measures, I can't say this strongly enough, it's not just about improvement in ambulation or bathing. right? Or dressing or hygiene. It's about stabilization of those functions for patients that have a high risk for return to rehospitalization. So I'm right there with you. Those are the key takeaways that I think that sometimes when you and I dive deep into maintenance, people really lose, but they're really the sink your teeth into takeaway points that people need to look at when they're talking about delivery of therapy and maintenance for the Medicare beneficiary. So I'm going to go
And I
on to
think,
that second.
well,
Oh, go ahead.
before you do though,
Sure.
I do want to share because we always try to be both practical, useful, and also real. The organization I was speaking with has not gotten through this without ADRs, without issues from time to time of being told that this was not paid for. What they were very clear about is they have appealed every time that's happened and been successful every time it's happened. So I think sometimes the I'm not going to do it is out of concern that I could get denials. And there's times where, sometimes that is happening in the initial round because you may have run into a reviewer that really doesn't understand that part of the benefit and is still stuck in the improvement standard. But I think to then turn around and say they've successfully refuted every one of those gives an idea that we should be stepping into this space, but be prepared, as you
Yeah.
touched on. And I think the next question is going to feed into is I can really understand this on a clinical level and be really excited about this and market this. But if my documentation has problems, then I could get denials that I can't refute. So
And I
I'll
think we have to look at, I'm sorry, Cindy.
no,
I
go
think
ahead.
we have to look at denials from the perspective of only a fraction, a very small fraction, like what, 1% of millions of claims are actually randomly pulled, right? Just through a regular edit. And so typically, I've seen more questions come up in targeted probe and educate. And right now in the pandemic, we're kind of in a hiatus. I guess they can start back. The Macs can start that back, but many of them haven't. And so the question is, it's not whether you've been audited or not. It's are you documenting soundly and strongly, like you're saying, towards those things that get us paid, skilled, reasonable, and necessary, whether it's along a restorative or an improvement course of care, or whether it's along a maintenance, a stabilization, prevention, or slowing of deterioration or decline course of care. And it has to make sense based on the presentation of the patient. And so when we get into these things like standardized measures, I think that we have to look at the measures as measures for the population. If they're not appropriate for a moderate or severely cognitively impaired patient that we're delivering restorative care to, the same is going to hold true for a maintenance course of care. The outcome is what is different, not necessarily who we are as clinicians or the evaluation we do or the service, or the choice of functional items that we offer. And Sherry, you jumped off that screen, so I'm not really sure why, but uh, in the situation where we have skilled maintenance and it may be appropriate, a 30-day reassessment should include quantifiable objective measurements whenever appropriate and can be administered in a standardized and validated fashion. And so if we don't have those instruments that can be applied and can be used soundly, safely, effectively, and validly to interpret the results for a cognitively impaired patient, then absolutely we can provide qualitative documentation rather than those objective measures of function. Ultimately, it really boils down to what are we trying to accomplish? We're trying to reduce caregiver burden. We're trying to enhance the safety, reduce rehospitalization rates, and those things that promote jeopardy or cause hazard to a patient that could increase urgent, emergent, or hospital utilization, those higher cost centers of care. And so I have been known to use more qualitative descriptive measures, but they may not be in a functional test, but they should be tied to functional impact. In other words, simply having someone increase standing time from 1 minute to 3 minutes with right, Cindy? We've seen those goals in restorative patients without a functional importance of that, i.e., the patient can now stand for 3 minutes and participate in personal grooming at sink side. It is extremely important versus just the patient can now stand for 3 minutes. I have to ask the big old so what? Who cares if it doesn't have a functional relevance? And so we as home care providers a lot, or Part B in the home clinicians, we're working with patients in their natural habitat, right? And so we can see the impact, if there is one, of being able to increase standing tolerance and safety and stability from 1 to 3 minutes. You know, a lot of times we'll see those kind of quantitative changes in numbers used by OT, and I'm like, but if it doesn't have a functional impact in self-care or in meal prep or something like that, it's a so what? It doesn't really matter. And the same can be said for therapists with gait. So what? They can walk a further distance. If that distance doesn't have functional relevance for them, then regardless of use of a test or measure, it really is not going to substantiate and provide a robust defense for why you're providing care and why it needs the skills of a therapist. So I kind of always go back to that skilled, reasonable, and necessary. And Cindy Moore, I hope that really answers your questions and helps give a little bit more fodder to the, you know, the clinical skills, knowledge, and judgment and abilities and expertise that we need to lend to our documentation as clinicians. Choice of an objective measure or not an objective measure is fine as long as it makes sense for the patient and we have documented it defensively towards skilled, reasonable, and necessary. Cindy, I didn't know
So
if you wanted to jump in at all.
Yeah, well, you know, every time I hear you talk, no matter what the context is, it makes me think of a question. So my question to you would be this, because I think when we think of tests and measures for therapy, we very much think of the timed up and go, the 5 times sit to stand, the functional measurements, and then think about cognitive type tests being the purview of speech language pathologists. So it kind of building off Cindy's question, as not just the population that has significant cognitive deficits where trying to get them to follow commands for a functionally based test doesn't really work. What are your thoughts about using instruments like the MoCA by PT or PT and OT as part of an assessment of our patient population? What would you think about that? I don't see a lot of that in the documentation, and then I'll see reference to forgetfulness as a comment, decreased cognition as an observation, but not really what that means or how that factors into a treatment plan.
Yeah, well, there are a lot of specific tests, especially in speech language pathology, right? And I have a niece who's entering her 5th year, graduating now with her bachelor's at LaSalle, outside of in the northeast part of Philly, for speech language pathology, and you'll see it related to, you know, aphasia. And things that happen after neurological insults. There's a lot of tests, but they're not limited to them. Things like the MoCA, the Montreal Cognitive Assessment, is absolutely out there, and it does a great job discriminating between, you know, mild cognitive impairment and Alzheimer's level disease processes. And they give you all the psychometric properties, and they have an entire booklet of how to administer it. So you don't have to be a physician or a psychologist or a psychiatrist or any, you know, or even a speech language pathologist to deliver these kind of measures that are out there. And, you know, we should be looking at these measures not just for patients with cognitive impairment that we're putting on maintenance courses of care, but also for restorative courses of care. I mean, think about how we're providing training, how we're providing education. What is the best format for these people to learn? You know, a great little story that I have is a patient that I had that had diagnosed Alzheimer's, and I did the Montreal Cognitive Assessment with her, and I found out that she had a lot of retained function in different areas. It's just that she did not have good memory recall, but she had some good problem solving according to that. And so I was able to build her an exercise program that, with her husband's supervision, she was able to complete. All he had to do was remind her to follow the instructions that she helped develop, and in the language that made sense to her, and pictures of herself doing it. And so it makes total sense that we are individualizing, right? When we think about prescribing these programs and training caregivers, if not patients themselves, for maintenance, understanding cognitive functioning, even if they're not formally diagnosed with dementia, under that umbrella of dementia or Alzheimer's, can be very, very helpful. And so I challenge you to go back to your professional organizations. The APTA home health section has just put out the Toolbox 2, which has a lot of different tests according to the different areas of impairment that we evaluate, and includes those things related to social determinants of health, cognition, as well as those impairments in gait, balance, strength, aerobic capacity, all those other things that we test as physical therapists and physical therapist assistants who have been trained in those measures can do. Because it really helps us individualize the program. So once again, it's not just about a maintenance program, but it's about individualizing that care and making it fit the patient and tapping into what strengths and capacities they have, Cindy.
You guys, I'm going to jump in real quick because I noticed we're talking a lot about maintenance therapy, but there's also the maintenance benefit for nursing. And I wonder if you could speak a little bit to how nurses would handle some of these issues with their cognitively impaired clients and patients.
Well, I'm going to just kick it off, Dee, and then probably wind it up and listen to you run. I think it's important to notice that the tool you mentioned, for example, the MOCA, is not a therapy specific tool. I don't have to be a therapist to administer. So couldn't nursing use that even in a case that maybe didn't have therapy at all to get a feel for some of those more mild cognitive related issues? Because I would think as much as we see documented in the care plan about medication teaching and disease management, and there seems to be an awful lot of teaching, and I don't mean any offense to that, to the nurses listening today, where therapy programs are viewed as very heavy, exercise driven. Nursing plans are very teaching driven, and I've always looked at that and said, but it says they have dementia, or it looks just like the same teaching as if they didn't. So what are your thoughts on nursing using something like the MOCA?
Well, these are not one discipline or discipline specific measures, right? So absolutely. In fact, when Sherry and I had our agency, it was standard practice that the admitting clinician, whether it be a nurse or a therapist, actually did a MOCA. And that was part of that comprehensive assessment and helped inform our M1700 items, right? The way we answered them. And it was shared with the rest of the interdisciplinary team, and it helped us to individualize our training. So for nursing, absolutely running the MOCA and understanding, where this person's strengths were. And just like with the exercise program for therapists, the medication training and education that was provided, what met that same sort of parameter to play to a patient's strength when there were some cognitive deficits. Because just because they don't have a diagnosis of cognitive impairment at some level doesn't mean that as people age they don't have some of those normal age related changes that happen, even if it's not a formal diagnosis. So absolutely, it was our practice, and these again are not therapy specific instruments. I think that they're good for everybody to use to get a better understanding of their patients and develop individualized care plans.
If I can add to that, Dee, I think part of what happens to all of us, all of the clinicians, is that we spend our time with individuals that have varying degrees of impairments. If they didn't have impairments or limitations or issues going on, they wouldn't be receiving medical care. So that's a given in our patient population. But I think sometimes we attribute some of this to, it somehow goes from an impairment to being normal. That, oh, they're just a little forgetful. Oh, they didn't quite remember what I said. But I think those tests can really help solidify some of those. And your example about the Alzheimer's person, I think we see a lot of records that'll just say Alzheimer's, and then here's the plan of care. But when it affects people slightly differently and what functions and cognitive abilities they still retain and others are more challenging, are really great to know, and how we shape the teaching. And I think very often when we see denials around nursing, and this not really being medically necessary, is they haven't really spoken to the individualization of how that teaching was presented, why it was presented, to whom it was presented, how often is the caregiver involved in this, how do we make sure all those steps, and I believe the nurses are absolutely doing those types of activities in the home, but I think very often it's become the checkbox equivalent of teaching and training that doesn't really talk about the skill it takes to customize your education in the best possible way for this person to retain what they need to retain to stay out of the hospital.
That is excellent. And I wanted to remind everyone that you have the opportunity to ask a question of these ladies by entering your question into the Q&A box. But also I've provided their email addresses should you have further questions after we finish the session. The next question that arrived early before the session was about telehealth and its relationship to the therapy assistants, the LPN, and whether or not they're able to provide telehealth, even though it's not reimbursed in home health as of yet. But once, Cindy, I wonder if you could talk to, once the LUPA is met, once you have met your LUPA number, talk to me about how telehealth can be an add-on to your program that is so beneficial to patients, and whether or not LPNs, PTAs, CODAs can provide that.
Well, Sherry, I thought when we went into PDGM and we got away from the single LUPA threshold, that this might be less of a conversation point, only because, and maybe it's a little tongue in cheek, there are so many possible LUPA combinations, depending on how the pieces come into play. I always said that they did this to make it so confusing that we would just focus on what the patient needed and not be hyper vigilant about the LUPA. Apparently I was wrong, because there seems to be a lot of discussion, more than I ever recall, about LUPA management, or the one that makes me twitch is LUPA avoidance strategies. That just sounds like, you know, dear CMS, come take a look at what I'm doing. Yes, we want to be financially viable as a home health organization. I totally get that. And I'm not saying we throw caution to the wind and don't pay attention to LUPAs at all in the broad sense. But I'm seeing LUPAs used as a, well, why would I do telehealth? Because those aren't visits, those don't count, they'll give me more LUPAs. I don't want to do maintenance therapy because those give me LUPAs. I don't want this kind of patient because they give me LUPAs. I'm not sure that there's anything about a patient diagnosis, a particular course of care, whether it's improving them or stabilizing them from a nursing or therapy perspective, or telehealth, that is automatically, I got a LUPA. And what I'm finding is folks are, as they dig deeper into their LUPA situation, are not necessarily finding that maintenance is the primary cause or telehealth is a primary cause. It really is about how are we managing patients from an interdisciplinary perspective, which if we think all the way back, those of us have been in home health a while, back to 2000, let's back it way up to 2000, when they took us off the pay per visit model. The whole point of going to episodic payment was to focus on the individual needs of the patient in an interdisciplinary way. It never excluded that we could do virtual visits or telehealth type activities. It simply set a minimum visit threshold, because they were concerned. If I'm going to give you back then 60 days worth of payment and you only went to the house once, well, that doesn't really seem to be fair, which is the whole point of having LUPAs. So once we cross a LUPA threshold, we are in a, this is the money we get. So whether it is, you know, I'm making additional visits because it makes sense for the clinician to physically continue to go to the home, that's fine. But if the needs of this patient can be enhanced by or supplemented by those virtual contacts, we can see, and many agencies in the pandemic situation have kind of had this door open, not in a pleasant way, but in a how are we going to manage these people way, are really seeing the positive impact. And I think we need to kind of break this idea that this is all about one particular telehealth thing, like a product I go buy that says this is me doing telehealth, and think of it bigger. Whether it is calling a patient to check in with them and determine whether or not they really do need an in-person visit today, and that's not, do I have time to fit them in, but Do they have issues going on? Are they doing really well? Maybe I don't need to go today. Maybe going a different day this week, when the daughter's there would be better. If it's, a monitoring type of the technology we're seeing about their activity, their completion of certain tasks. And again, don't assume it's just a fit tracker and it's about exercise reps. They're following through on disease management strategies, tracking and trending those, and we remotely check in. I think there's a lot of things we could be doing. And so again, I think we get very still stuck in the only thing, our only currency, as it were, is a visit. But that's not technically how the model was made. LUPAs were really there just as a stopgap. And you have thoughts on LUPAs, Dee?
Yeah, well, I mean, we can't help but constantly have our attention drawn to lupus because, as of what was it, last July, CMS did the Office of the Inspector General did a report that looked at claims slightly above the threshold that triggers a higher, the 30-day period payment. And it was a little bit scanty, but the way they addressed that was CMS could have saved 192 million by targeting home health claims for review with visits slightly above the threshold that triggers a higher payment. And so, if we want our attention drawn away from it, it seems like it always comes back to the money, right? That's what the OIG looks at. And so I think that if we constantly just try to, like you're saying, give the patient what they need, look at what we're trying to impact, satisfaction, right? Our CAP surveys, outcomes, reducing higher risk or higher centers of care. That's the take home message for home care. We can impact that in the home environment tremendously. Or by the provision of care in the home, because we can impact the home where when they're in facilities, they're going to tell us whatever they have to tell us or whatever they think is the truth because no one sees their home, right? They're in a controlled environment. And so if we can just start to focus on what is important and telehealth and Medicare knows, CMS knows telehealth. The recent advice from MedPAC is that let's continue to explore the delivery of telehealth, even if it's unpaid in these different settings, regardless of the setting of the environment or the waivers that exist solely along the pandemic. Let's keep these lines of communication open. We were forced down these roads. Let's continue to do that because it may solve for some of those issues related to visits. But I'm with you on that. If you don't want your attention drawn to it, then don't put attention on it, right? Put attention on the patient. Stay focused on the patient. Stay focused on what the regs say about what you want to document, demonstrate individualized decisions for care, reflect the skills, knowledge, and judgment in the statements and the narratives that the clinicians provide on the patient, and that goes a long way to checking all these other boxes, right? I mean, it's good to get your reports. It's good to look at your Pepper reports. It's good to look at your surveys and your stars rating and all those things. But having sound patient-centered delivery of care, understanding the full component of the benefit for nursing and therapy services goes a long way to kind of answering these questions that come up, and LUPA being one of them.
To adding on to that, Dee, I think, you mentioned the issue of episodes that basically just cross the LUPA line. That's not new. They've been looking at those 5-visit episodes for quite a while now, out of concern that it was just one more that then put it into the higher payment group. And so that's something when we look at our data, that if we're seeing a lot of just over the mark, we better make really sure that the documentation is clear about skilled, reasonable, and necessary services, and it doesn't leave the impression that this was one of those LUPA avoidance strategies, and we made sure somebody went one more time just to break it, because when that becomes routine, that tends to raise suspicion. And speaking of suspicion, Dee, did you see the most recent stuff coming out of the OIG? Not the OIG, MedPAC, that was talking about, I guess they're happy with everybody else but home care. They're recommending either, hospitals, get a little bit of a raise and this setting stays the same. And, oh yeah, home health, you need another 5% cut. When I saw that, I posed the questions to a few people because I'm trying to figure out why we always get the cut. I mean, did we make somebody mad? Is somebody just really fed up with home care? And the feedback I'm getting is the concern keeps going back to MedPAC's perception that home health margins are too high. Where do you think that, avoid the lupa, but don't provide so many visits. Just, don't provide so much therapy, cut back on the nursing, keep it right as, as tight as we can. Do you think there's some correlation between that? And I know people can debate for a very long time about whether or not they think MedPAC's data is accurate about margins, but do you think there's a correlation between this almost ratcheting or constricting of visits under PDGM and MedPAC continuing to say, see, I told you their margins are too high?
Cindy, I honestly, I don't know what to think sometimes when it comes to MedPAC. I know that there is a lot of lobbying. I know that the highest cost centers of care are in acute care facilities, yet they continually, they're seen as essential, and they are essential. But we have a very tertiary mindset for healthcare in this company, in this country, right? We very much, and this is my opinion, we very much, will allow people to smoke and drink and eat crazy foods and not manage their weight and not manage their genetic risks and put them on every medication. We won't pay anything for prevention and getting a gym membership and a nutrition counselor. That's not standard preventative care. That's very hard to fight for under a lot of policies, but yet we will give 75 medications and 35 surgeries and all kinds of specialists for future cardiovascular problems, when they hit their 50s and 60s, right? To keep people alive forever. And so, I have it's very hard to look at where costs go in this country. And it seems like by the time people get to the need for acute care and emergency and urgent interventions and management of these chronic diseases, that we've kind of missed our mark. And home care kind of falls in that. There's a lot of things we can do to prevent future potential problems, sequela from disasters. We look in people's refrigerators. We see their normal behaviors. Unfortunately, I don't know that our past history has always served us well. When the data starts coming out, and I don't know that doesn't continue to give us a little bit of a black mark. But I will tell you this: the pandemic has proved to people that home is where people want to be, home is where we can be safe, and home is where they can still get great care. And how do we know that home care is not going to go away? It may be modified, it may be revised, it's going to undergo different iterations, is because they're looking at skilled nursing facilities at home. They're doing hospitals at home, because home is where people want to be. And home is a very cost-effective place to provide care. So, these continual margin shifts, I probably have much stronger bias than I would like to admit. But I think until we can start to look more towards prevention and promotion of health activities in the front end, we're going to continually see that a number of our dollars go to back end care delivery, of which we are a post-acute setting. But I think we have opportunities, with wellness and population health, things that maybe we can start embracing when we see our patients in their, like I said, their natural environment, and we can start to address those for future prevention, education strategies, training. Maybe something we can do. But MedPAC, I don't know.
But continuing on that thought, Dee, I agree with you. I've long felt, that being on episodic payment is an opportunity to address the clearly urgent issues going on with our patients, but also to take that opportunity to look toward their individualized future and what their risks are and things that they could proactively do. You've heard me say many times, I don't know why we call them fall prevention programs when you get into them by falling. If your most recent fall is how you ended up in the fall prevention program, then we didn't actually prevent a fall. We're trying to reduce them going forward, but that doesn't really match up with calling it prevention. So I think we have, some work to do on an interdisciplinary level to look at that holistic opportunity of how does every visit, regardless of who's making it, advance that overall plan that isn't just about mitigating the risks right now that they are experiencing related to this acute injury, exacerbation, or illness, but what do we potentially see down the road and how do we manage that? But I think that feeds into the question that just came in, and it has a lot to do with the issue of, if we're focusing on stabilization, whether it's from the maintenance perspective or skilled M&E from nursing, what does that do to publicly reported outcomes? And is CMS aware? I can tell you by being on several technical expert panels, they're aware. They're aware of this growing pushback about the importance of stabilization and why their measures need to be recalculated. We're seeing the most headway on that with respect to value-based purchasing and looking at things like taking functional questions and combining them into more of a metric that would include stabilization type things. It's just hard to move that needle in the short term because there's been such a historical focus on making those measures about improvement and then using home health compare to ultimately drive stars. But I think it's going to take a twofold approach to really change it. And one is for folks to actually be providing maintenance therapy and skilled M&E so that it's showing up on claims data that these are maintenance and M&E patients. I think the hesitancy of the industry to provide this level of care, to own it, to call it that on the claim, has allowed CMS to believe that that is part of their benefit, but there doesn't seem to really be a huge need for it because they're not seeing a lot of it show up on the claim. So if you're not billing for it, then they're trusting that you've determined that the patients don't need it. The other part is advocacy. So whether it is, the latest rule coming for the payment methodology change, or when they put out, comment periods around value-based purchasing, comments around quality measures, we need to be commenting. We need to be commenting about the concerns about that stabilization element. I know they might be getting sick of seeing that comment coming from me, but it's going to have to start coming from a lot more individuals in this setting to say, what is the value of stabilization, why that matters, why your calculations need to ultimately be changed to put a highlight on that, because now it doesn't look like that. It looks like we don't get credit and somehow we're being penalized in the outcome world when you only talk about improvements. So again, I think the providing of it and the advocacy for that, anytime we have an opportunity to speak directly to those who makes the decisions, we need to take full advantage.
Cindy, that is such a great point. And I also wanted to mention that the Medicare advocacy group, Judith Stein, they are constantly asking for stories from the front line regarding maintenance therapy and other issues in home health. Because when Dee mentions MedPAC, we're still trying to figure out who the members of MedPAC are. It's kind of a secret society, skull and bones of home health, if you will. And they need to hear from more than one person, but also through the advocacy groups that do a lot of lobbying on behalf of home health. I wanted to take the opportunity, as we're getting within about 10 minutes of finishing, and mention that this recording will be portable for your clinicians and staff. It is downloadable in an MP4 format, and you can load it onto a thumbnail so that it can be listened to in the car between patients or on the rides to and from work. So we definitely encourage that you share this with your clinicians and other staff members in your agency and friends and colleagues, because we're going to plan on doing these once every couple months. And as hot button issues come up, you can always pre-submit your questions. Usually we answer those questions via email, but we will include them on the next Q&A so that more people can get those answers, because more people have those questions, but oftentimes either forget to submit them or don't mention them during the time of the recording. So what I wanted to do was give Cindy and Dee both the opportunity to give some closing thoughts on today's session and maybe mention some things that are upcoming that are pretty exciting. Who wants to go first?
I'll go first. I think that my final thoughts are I really appreciate this opportunity to be asked questions and answer them. I think it's important that you understand that this is, my personal and professional opinion. And if we don't have answers, and not that I think that we're easily stumped, but if we do get stumped, we absolutely will be able to follow up with you and get you the answers to your questions. We think this is a great platform, a great format, a great offering, and hope to share, your thoughts, or your concerns with the industry in the future, and look forward to you at future sessions. Cindy?
I would echo that, Dee. I always feel like I learn something probably more from the questions we get asked than I would have considered before. I love hearing what people think about different issues, and it tends to spark other ideas. And so that's why we decided to go with this format. And yeah, live and not prepped can be a little rough around the edges, but I think that our hearts are in the right place. And as Dee said, we're never going to blow smoke on an answer. If we're not sure how to answer a question, we will find those resources. So don't be afraid to ask. One thing I do want to mention, because Dee and I have been hard at work trying to help folks with this maintenance issue. And this is not, shameless self-promotion. This is just letting you know about some resources that will soon be available. Dee and I have updated our book about maintenance therapy. We've shifted the focus a tiny bit. It is now about provision of maintenance in the home under Part A, under Part B in the home, or Part B in the clinic. We see a natural connection between patients that are being served in home health that may still need maintenance but don't qualify for home-based services anymore, and how would we get them to an appropriate outpatient program and facilitate a transfer to continued maintenance. Also to our outpatient counterparts that may have patients that are missing appointments or falling asleep in the lobby because they're really not ready for outpatient, and how do we facilitate that type of referral back to home health. We've also finished with MedBridge a series of video courses about maintenance therapy, again, target audience being home health, this time home health A and B, and the clinic. So we are going to be sending out information to those of you who sign up for these sessions. We're not bombarding you with it. Rest assured, we're not going to stalk you or nothing. But when these resources are released, and we should be learning more about that later this month, we want to make sure that you have that information if you're interested in those resources, because we know that maintenance is not simply a let's review the regulation and let's start to do it. And even as we start to move forward, how do we make sure that we have all of those things in place? Because circling back to what I said before, I think one of the roadblocks I see to continuing the conversation about changing outcomes and concerns about expanding value-based purchasing is the claims data is not indicating a significant use of this part of the benefit in our setting. And again, we can go back to issues around JIMO, we can go back to the improvement standard, we can say this is somehow related to CMS or MedPACs, whatever else. But realistically, what they're saying is you have the code, you're the clinician, you're the decision maker. If we're not then seeing this being provided, then your patients must not need it. And if so few patients are getting it, this really shouldn't be enough to dramatically impact your outcomes. So why would I change all these outcomes for something that doesn't seem to be significant enough to change that? So we're not suggesting we inflate the use of maintenance therapy or start putting everybody on M&E, but you really want to make sure that those parts of the benefit are being used appropriately. And that will help to make the case that, yes, this percentage of the home health population is being served with an eye towards stabilization. So how do we then carry that into how our value is quantified in the future? But again, circling back to Dee's point, and I want to kind of close driving this home, the biggest measuring stick with all of this is reducing rehospitalization. And how do we ensure that our entire interdisciplinary team, whether it's restorative, maintenance, observation, management and evaluation, the nurse, the social worker, the aide, are we building our teams that say, as each person from our organization goes into the home, is their primary thought on that visit, what am I doing today for this person to reduce their risk for going into the hospital? That is where we're going to have to get to as an industry to really then become that well-oiled interdisciplinary patient-focused team we keep talking about. I think a lot of it is all these other programs we try to lay on it, as opposed to saying, what is this patient situation telling us? Is there risks? How are we working to mitigate those risks? And how are we ultimately dealing with the hospitalization issue? So we look forward to the next time we get together, but you have our email addresses. If you have any specific questions between now and then, you'll see notification coming from Sherry about gathering questions for the next call. So we welcome feedback in between. And with that, Sherry, if you have a final thought, I know mine was a little long, and you got the Gators thing up again as if nobody knew you were a Gators fan. If you want to just, send us off for this month's call, that'd be great.
Yes, I would actually. I want to remind everybody that we can also be reached by phone at 1-833-K&K HELP, which is 565-4357. That is a toll-free call. So if you're not able to use your email or a subscriber to our newsletter, make sure you reach out by phone. We enjoy doing these sessions, and we're planning to do another one in May. I apologize for the screen kicking off. Have no idea how that happened. We have some gremlins in the machine today, and hopefully we'll get some of those ironed out before the next session. But thanks again for joining us. And remember, all of your clinicians have a value beyond just their visits. Have a great day.